And so without further ado, I do want to talk about our presenter that we have here today. I'm going to go through and tell you her bio here quick and a little background of who she is. Chelsey Valeri is a licensed master social worker who received her master's in social work from Case Western Reserve University. Chelsey is a certified EMDRIA therapist trained in eye movement desensitization and reprocessing. She's also trained in advanced modalities of trauma therapy, including somatic experiencing, attachment-based EMDR, and structural dissociation theory. Chelsey is a compassionate healer with 10 years of experience utilizing a highly effective multimodal approach to therapy. She is able to assist her clients in discovering the origin of presenting challenges and work towards changing self-destructive patterns while moving into emotional healing and freedom from the pain of trauma and addictive disorders. Without further ado, I know we have our cameras off and we have our sound off, but I'm going to just pretend that everyone's doing it with me. Let's give a warm welcome and a round of applause for our speaker, Chelsey Valeri, here today. That was a strong one-person clap, but everyone else was doing it too.
Thank you, Jordan. Thank
Absolutely.
you. This is so weird to present to a screen. I can't see myself or anyone else. So we'll see how this goes. But my name is Chelsey Valeri, and I am located in Scottsdale. I have a private practice called Healing Foundations Counseling. So a little to kind of go off of what Jordan said, I have 10 years experience working in substance use treatment and mental health. Why I have really moved my practice towards treating complex trauma is because of the vast number of people I have seen over the past decade not get better from their addictive disorders and other mental health issues. I have, witnessed numerous relapses and unfortunate deaths because people just seem so stuck in old patterns. And when I first entered the field, there was a lot of, talk of treating PTSD. And, 10 years ago, somatic work was really just coming to, really just being taught to the public. EMDR had been around for a long time, but it was primarily used for treating simple event PTSD. And over the years, I've recognized that most of the people I see and have treated really suffer from complex trauma. So I've spent the last several years learning how to heal the wounded parts of the traumatized psyche, hence the name of my presentation. So I will get started. Okay. So this is a quote by Bessel van der Kolk, who wrote The Body Keeps the Score. And if you haven't read this book, it's absolutely phenomenal. He stated, "We have learned that trauma is not just an event that took place sometime in the past. It is also the imprint left by that experience on the mind, brain, and body. This imprint has ongoing consequences for how the human organism manages to survive in the present. Trauma results in a fundamental reorganization of the way the mind and brain manage perceptions. It changes not only how we think and what we think about, but also our very capacity to think." And I'm sure there are, several people listening to this who have a trauma history or know someone who suffers from PTSD or other trauma-related disorders. And I think it's just so vital to understand the neuro the neural network impact that, I guess, the neuro changes that trauma has on the brain and on the nervous system. Bessel wrote the book The Body Keeps the Score, which, if you haven't read it, you really should, because it is such an amazing testimony to the stronghold that any traumatic experience has on the nervous system development and what that means for recovery. So looking at how complex trauma or complex PTSD is defined is the chronic traumatization over the course of months and years, which often happens across different developmental time periods in one's life. So most individuals who I see who come to me to be treated for complex PTSD have suffered very traumatic childhoods. And while it is possible for adults to develop complex PTSD, in situations such as sexual exploitation and trafficking, severe domestic violence, and in other situations that really contain severe interpersonal intensity. Most of my clients started experiencing trauma very early on in life, some even in utero. And a lot of the research is starting to show that in utero trauma really sets the kind of the foundation for the development of PTSD symptoms based on the nervous system and the developing brain of an infant. So it's important to remember that unlike a simple event PTSD or a simple PTSD event, the injury or threat to safety with complex trauma is repetitive, prolonged, and cumulative. So it is not a single event. Another way to describe it as a single event, trauma has a beginning and an end, or it has edges. And often the experiences that clients have who suffer from complex trauma, there is no beginning and end, or if there is a beginning and an end, it quickly moves into another trauma that is similar or in a different area. So looking at how trauma impacts a person, it really causes some nervous system dysregulation. So our nervous system is designed with the parasympathetic and sympathetic parts to activate and deactivate all throughout the day when we experience, daily life events. If you walk out to walk to your car in the parking lot and almost get hit by a car, your nervous system is going to activate. But once you realize you're safe, it's going to deactivate and go back into a window of tolerance. And you'll hear me use that term quite a bit. But when your nervous system goes back into the window of tolerance, it is functioning, within its normal parameters. If, for example, you did get hit by a car, your nervous system is going to stay activated until you know you are okay and safe. And then it is going to deactivate and find neutrality again. So you can imagine what prolonged and repeated trauma does to the nervous system. Unlike a regulated nervous system, which really looks like, if I were to draw this, I often draw it for my clients, but it looks like rolling hills, nothing too sharp or steep. And when you look at a traumatized nervous system, it is often looks like very steep mountains and drops because the activation and deactivation happens so quickly, and there is virtually no ability to regulate. So neurobiological factors, for any of us who took Psych 101, we know that the desire and need for connection and attachment happens in utero and for the first 5 years of life. When there are traumas that interrupt that attachment development or attunement development, it really does impact the way the brain develops, and it can create pathways, neural pathways that are representative of that trauma. Those who have PTSD or trauma-related disorders are also going to suffer or have difficulty with their affect. It may be really incongruent to what they're talking about and even what they are feeling on the inside. Many people with a PTSD diagnosis suffer from other mental health disorders. I think the average number of mental health diagnoses that someone with PTSD or dissociative disorder has been diagnosed previously is about 7. So unfortunately, dissociation and dissociative disorders are really underrepresented, I believe, in the mental health community because it's not something that most people learn about in detail, or we are taught to believe that a dissociative disorder is on the very extreme part of the spectrum when it comes to trauma-related disorders, and I'll talk about that in a little bit. Substance use and other addictive disorders are very common, in addition to self-harm, suicidal ideation, and suicide attempts. So Dr. Fisher is another foundational member of the complex trauma community, and she stated, instead of developing a sense of self, chronically traumatized individuals often develop different parts of self. So this brings me to dissociation. So dissociation is a mental process that causes the lack of connection with a person's thoughts, memories, and sense of identity. And while there is a pretty long continuum of severity of dissociation, most people and most of us who are in this room right now have experienced some level of dissociation. Most of us who are really busy and juggling a million things probably experience mild forms of dissociation daily, whether it's not being 100% present on your drive home, not remembering where you put your cup of coffee. I often, put bread in the fridge or milk in the cupboard, doing things when I'm kind of scrambling at home trying to get out the door. It's often referred to as autopilot or zoning out. However, those who have experienced chronic trauma or simple event traumas often suffer from moderate to severe levels of dissociation. You can also refer to this process as a state of non-realization. So when someone experiences trauma, their mind and body instantly goes into a state of organizing the information, often into different fragments. If the trauma is very severe, people often suffer from depersonalization, which is removing themselves from the experience of the trauma. People also compartmentalize their experiences, memories, and perceptions of what happened in order to remain in a survival state so they can continue functioning. Some people feel a disintegrated sense of self out of body experiences. Again, so often my clients describe themselves as feeling like a jigsaw puzzle that doesn't fit together properly, and they aren't sure how to put the pieces together. Many people with severe childhood trauma suffer from childhood amnesia, time loss, or blackouts. I have tons of clients who come in and they're like, I don't remember anything until I was 12, or I don't remember anything negative from my childhood, but I have all of these symptoms. And while my job is not to make memories appear, it is, something I really take note of. And it can be a pretty telltale sign of trauma if they have absolutely no memory from childhood.
Looks like accidentally muted here.
Okay, am I unmuted?
Yep, sorry about that. I think a little technical glitch.
No problem. Another form of kind of daily dissociation that people may experience is forgetting conversations, special occasions. Some people even forget, how they got to their office or got home. While they intellectually know that they drove home, they have virtually no memory of the experience of getting there. And it's important to remember that dissociation is a strategy for survival. So common clinical diagnoses of clients who experience moderate to high levels of dissociation, complex PTSD, although this is not in the DSM, and I'm unsure why. I guess that would be a whole other conversation, but I am going to use the term complex PTSD, and most people do who work with treating complex trauma. Trauma-related borderline personality disorder, dissociative identity disorder, or DID. This was historically called multiple personality disorder and has been represented in Hollywood pretty poorly over the last several years. And we'll get into a little discussion of what DID more commonly looks like. And then dissociative disorder not otherwise specified. And this is where most of my clients fit on the dissociative spectrum. So the big question, how does complex trauma create the foundation for dissociation and splitting of self? And that may sound like a mouthful, and it kind of is in understanding this process from a neurobiological and nervous system perspective. So when all of us are born, and if any of you have infants or toddlers, young children at home, you know that they swing from one ego state to another really quickly. And that's how all of us came into this world. So we had a very unintegrated personality. And the ego states really got us through, playing with our friends, seeking out food and comfort, having a relationship with a caregiver. So it's not until the ages of between 6 and 9 that these various ego state parts really start to integrate into one personality. So you can imagine when severe trauma or continuous trauma takes place in childhood before that integration, the trauma can severely interrupt the natural integration process, leading to very conflicting ego states that are unable to merge together. And what I mean by that is, if you were to kind of visualize the jigsaw puzzle, it's a really good representation of this theory. And inside one's psyche, the jigsaw puzzle over time, over the first few years of life, the pieces start to come together, and you see a developed, wholesome child, right? One that seems to kind of have it all together. What people don't see is the lack of integration of some of these pieces that have been interrupted by traumatic situations. Often at the hands of caregivers, the inability to merge is very severe. And I think this is why most people think of kids as being fairly resilient. I hear that term all the time, and I pretty strongly disagree that they're resilient. I think parts of them are resilient, and parts of them learn to cope with situations that they need to cope with in order to continue participating in life. So maybe 50% of the child is really resilient because they have dissociated from what happened to them and seemingly go on, living their life as normal. Other kids really start acting out, and I'll talk more about what that means for the structural dissociation of the personality. So the psyche is quite amazing. I mean, our brains are just so fascinating. And when we experience highly traumatic or distressing situations, our psyche really develops mental barriers to keep the painful events of those memories out of our awareness. Because if we were aware of every traumatic or distressing thing that we've experienced, all of us would be incapacitated to function in life. So I'm going to pause here and ask if anyone has any questions before I get into structural dissociation theory.
I don't see any right now. We can give everybody a minute if you have a question and want to throw it in there in the chat.
I have a comment.
Okay.
I think you're right. I don't think that we are resilient. We just cope with situations, and I'm talking about me too. Then later on in life, things come up, and you haven't. You're not resilient. Then there's so I think that we try to eventually but I think we get older
Sorry, Alejandra, your connection is kind of going in and out.
Alejandra, if you want to
I'm sorry.
If you can put more of that in the chat, maybe I think that might help a little bit with it too. But thank you for saying all that. We appreciate that. It's a good comment.
And Chelsey, somebody asked, can you briefly explain ego states?
Yeah, so ego states or parts therapy, those are kind of two interchangeable languages or terms used in psychotherapy. But an ego state, okay, so how do I could get off on a tangent, so I'm going to try to really simplify this. We all have an ego state of needing hunger met, right? So we will, when we're 2, we will do anything to kind of solve that ego state of hunger, okay? Sometimes that can turn into a perpetual need for food. So that can be viewed by a parent as maybe selfishness or lack of patience, or kids are really entitled. So the part of a child that learns to get that need met, I guess could be said to be an ego state. So the ego states handle the various needs of what a child needs or requires to feel secure. And then when we get into parts work or emotional parts of the personality, those are representative of stubbornness, representative of, there's stubbornness, I'm going to do a case study later, but a personality part could be shut down. The part that feels a big disconnect from others because it was traumatized, a certain ego state within that person was traumatized, leading to a specific emotional part. So I think when I present a case study, that will help define that more. So I'm going to...
I don't see any other questions. Thank you.
Okay, so structural dissociation theory. If anyone is interested in learning more about this theory, there's a book called The Haunted Self, and there are several trainings I know in Arizona, well, a couple in Arizona that teach about structural dissociation, which are very helpful in breaking down the haunted self, because it is an extremely heavy read that leads people pretty confused, even one chapter in. So I recommend finding someone who, and I can put some names in the chat after, of people who teach structural theory. So structural theory, again, is a survival strategy to cope with a traumatic experience or environment. The theory believes that the psyche splits into two systems, the action system and the defense system. So the action system is the system for daily living. This is also referred to as the ANP, or apparently normal part of the personality that is usually online. Okay, so this is the part of the personality that we all see of one another. It's the part of the personality that you're going to see your coworkers live in day to day. So again, this is for functioning and survival. This part actively avoids the memories and acknowledgement of the traumatic experiences. The defense system, or the emotional parts, are activated when a person feels traumatized or re-traumatized. So it's important to note that people can feel like the trauma is happening all over again, even when it's 20 years old. So what that means is that the emotional part of their personality that was developed at, say, age 5, when a trauma was happening in the house, really became frozen in time there. So they may have developed an emotional part of themselves that just complied. Okay, they maybe just complied to their surroundings, and they have carried that into their adult life unconsciously, of course. So maybe they find themselves always complying when they're at work, always complying to their partner, even when it's unhealthy. So that will come up and really start to hijack the AMP when the person feels very similar feelings or sensations to what they did when the original trauma happened. And often this is so unconscious that people are not aware that they're doing this. And that's part of the dissociative process. So there are 3 levels of dissociation: primary, secondary, and tertiary. And this is a pretty simple explanation of what happens when structural dissociation of the personality starts. So if you look at type 1 or primary PTSD, the person has an ANP, apparently normal part of their self, that gets them up in the morning, eats breakfast, drove themselves to work. On the way to work, they got T-boned by a drunk driver. Okay. In that moment, an emotional part of themselves is going to develop that is absolutely terrified to ever drive again. And maybe it's because they were turning left on a yellow light and then they got T-boned. So the person may have such a fear of ever turning left that they can't do it. They become absolutely frozen when they are forced to turn left again. Treating that primary PTSD experience with EMDR is fairly simple because it doesn't include other elements of safety, as long as no one died in the car accident and there weren't other consequences. This is assuming that both drivers walked away, and while they were scared and there was some fear, the fear is primarily removed once the accident happened. Okay, so, and the fear is only attributed to driving and not other areas of their life. When you move into secondary trauma or complex PTSD, or even extreme stress disorders, the ANP is still the main functioning part of the personality. But over time, throughout the years that the client experienced numerous traumas, maybe they grew up in a very alcoholic home, one of their parents passed away when they were young and they witnessed it. If there was sexual abuse in the home, they're going to start developing multiple emotional parts of their personality that allow them to function in their house, maybe at school, with their friend group. They're going to develop what seems to be multiple different personalities or areas of their personality. But if they have a single ANP, they do not move into a DID diagnosis. They have one ANP and multiple emotional parts that come on and hijack, make people on the outside really question, is this person, who is this person? What version of this person is there? And within reality, it is different emotional parts kicking in that feel re-traumatized. When you move to tertiary PTSD, this is where multiple apparently normal parts of the personality or the daily action system develop. So people can develop 2, 3 more main parts of the personality that all have EPs or emotional parts attached to it. This is when someone's diagnosed with dissociative identity disorder. And the treatment for dissociative identity disorder is long and grueling and really takes a team. People often have mental health symptoms that derail them from any functioning, but not all the time. I have worked with several people who have DID whose ANPs keep them pretty stable majority of the time. I think every person, besides one that I work with who have DID, were not diagnosed until their 30s. And the theory behind that is that ANPs have done such an amazing job at really allowing them to function throughout all areas of their life. When the emotional parts that were frozen in infancy, toddlerhood, young adulthood, start to want to catch up to the ANP. So, because maybe in adulthood, they're getting careers, they get married, they have kids, those emotional parts are going to be triggered. And when the ANP and the EPs don't really line up or merge or integrate together, someone starts having symptoms. And that's very true for secondary and tertiary. So I'll open it up for questions on that, since it's somewhat complicated.
Chelsey, is here a good point to ask a couple questions?
Yes.
Okay, so the first one is, how do dissociative disorders present differently from reactive attachment disorders?
Oh boy. Okay. So a dissociative, I don't know if there's a simple answer to that, because it would be looking at the foundation of the client's experiences. And I believe someone could have reactive attachment disorder, RAD, and a dissociative identity disorder or a dissociative disorder. So I don't know exactly how to answer that, but There are some tools that you use to screen for dissociation, and that's the DES, and there's an adolescent version as well as an adult, and then the MID, which is a much longer screening process. I think it's important to note the DES is not diagnostic, but it does, I use it with all my complex clients to gain an understanding of their level of dissociation and area in which they dissociate in their life. So I think clients could have RAD and dissociative disorder.
Okay, the next one is, do you think emotions are stunted and can grow, or do those emotions in trauma experience stay frozen until trauma is experienced again?
I think both. I don't think emotional parts are 100% stagnant. I don't think they just stay stuck all the time. But I do believe that they have some rigidity because they have a purpose, right? The system developed the emotional part for a purpose and reason in the moment of the trauma and to carry the person through other stages of their life. So the emotional part is going to continue coming up as long as it feels it needs to. Right. And this is where we do a lot of parts work, understanding these different emotional parts and how old they are, what the system. So when you think of the system, it's the person's overall psyche, how the system sees the emotional part functioning and what its purpose is. But I do believe emotional parts, as they don't feel needed anymore, can back off. And I think that's kind of what you're asking. But I think most people with secondary dissociation really do need prolonged therapy.
Okay, and then let's see here. Another one was, what does the ANP stand for again?
Apparently normal part of the
Normal part. I knew it was normal part, but I couldn't remember the first word. And then it looks like the last question is, so are EPs developed based on fight, flight, freeze response to a traumatic event?
Yes, so that's part of it. And I guess the ANP could really be in a state of fight, flight, freeze. Okay. Most EPs would be in the flight or fight. So an ANP is going to really be in a freeze state because it's apparently functioning. Okay. It's doing all the things the trauma cannot do. So if you think of the ANP as being completely separate from the traumatic experience. So EPs are really developed when the system moves outside the window of tolerance.
Awesome. That's all the questions right now. Thank you.
So again, here is the severity of dissociation. So most people, for example, who take the DES, who do not have trauma history, are going to score under a 7, and they would be considered healthy in the realm of dissociation. Primary dissociation is going to score somewhat higher than that. Again, with a single event trauma, they may experience high levels of dissociation when it's associated with the event or something that reminds them of the event. Most people with post-traumatic stress disorder score about a 30 on the DES, and then in between 7 and 30, that's where most people lie who have anxiety disorders, eating disorder, borderline personality. People who score, or who have been diagnosed with DID, I should say, score over, I believe it's a 45 or so. And while it's not diagnostic, they have kind of lumped people into categories based on their scores and diagnoses. So some basics. It's really important to understand that our personalities are a system of ideas and functions that determine our character, behaviors, and thought. So the lack of the integration, like I've been talking about, of these parts can really result in the dissociation of the personality because it is truly unsafe for the personality to integrate together. If someone, so another kind of phase description that I use for my clients is phase 1 knows that the trauma happened, but that's as far as it goes. Phase 2 of trauma healing is knowing that the trauma happened and 100% of the person knowing it happened to them. So a lot of people can have an intellectual idea that something happened to them when they were younger, or they know they were sexually assaulted, but they don't feel it. And I think this is where a lot of mistakes were historically made in trauma therapy, because it was, highly based in CBT, is 50% of a person who you're talking to may know, and when I say 50% of a person, 50% of their system or psyche knows that the trauma happened to them. But the other 50%, represented by emotional parts, has really been dissociated from the fact that the trauma happened. So the apparently normal part that's online and talking to you can present as though it's healed from the trauma, because it has to present as healed in order to continue functioning. So when, I don't even remember my first thought with that, I got off on a tangent, but when you actually take a look at the different parts of the personality that have been broken down during a traumatic event or a series of traumatic events, that's when you're going to truly experience overall integration and healing. So the CBT portion of trauma therapy, while it's very important and needed to calm, some people's nervous systems, it's not, it really isn't the method that I use to find integration within the personality so the whole self can heal. And then the third phase of trauma healing is knowing the trauma happened, knowing 100% that it happened to you, and 100% of that person's being knowing that the trauma is over. So as soon as we know the trauma is 100% over with every fiber in our being, we will stop experiencing PTSD symptoms. We experience symptoms because part of our mind and body feels that the trauma is going to happen again. So we're anticipating it, right? So we live in a constant state of fear, or certain things in life trigger the feelings and they feel re-traumatized. So as long as we're living there, true integration and healing hasn't happened yet. And that process, really from phase 1 to 3, can take years depending on a client's history. And another part of the integration process is being able to reprocess the trauma without going outside the window of tolerance. So without having emotional parts hijack the healing process. So a case study, female, age 21 to 27. She presented with chronic substance use for 10 plus years, impulsive sexual behavior, previous PTSD diagnosis, and a self-harm history. So her background was she was raised by a 2-parent household. While the outside seemed pretty perfectionistic, there was a generational alcoholism and addiction on both sides of her family, which created a lot of unhealthy attachment patterns and lack of boundaries within the system from a generational perspective. In the nuclear family, there was a lot of fighting, gaslighting, and physical threats between the parents. The dad, it was discovered later on, had a fairly severe sex addiction that led to a lot of infidelity, which both kids in the house were aware of as they started to get older. The client also experienced suspected sexual abuse from her teacher in first grade, although she has only one flash of the memory and no other information. She has a lot of symptoms that would correlate with early childhood sexual abuse. She also experienced extreme bullying from a peer in first and second grade that included a lot of stalking and constant fear. So the dad, again, engaged in numerous affairs, and the children watched the mom be really avoidant and perfectionistic, trying to keep everyone in the house together. The parents split when the client was 10. This caused the parents to suffer financially. They moved 12 different times while in the same city to 12 different homes. So this caused a lot of unrest within the family system and within the kids' security. Clients started in self-destructive behavior right around age 10 to 12, and then she started using substances at age 12 pretty regularly. She experienced numerous traumas in her teenage years. She started running away, getting into bad relationships. She developed a chronic illness and experienced medical trauma, several sexual assaults, violent rapes, and abortion. When the client was about 18, she started reporting auditory hallucinations. It was kind of chalked up to extreme drug use at that time by a psychiatrist. She started feeling extremely disconnected from all of her experiences and everyone in her life. She reported not remembering anything from childhood. She started to act out impulsively with sex and using her body to obtain drugs. So this is one of the first things I do with people when they come into my office. It's called Fraser's dissociative table technique. And I should caution everyone that while it's outlined as a stabilization technique when working with dissociation, it can be quite disruptive to the client's system if they have zero, awareness of their internal experience. So when I used Fraser's table with this client, she did experience some disruption and high levels of anxiety and dissociation. So we broke it up into several different sessions. And the table technique is available online, and I can post a link if anyone's interested. But what it is designed to do is organize the system, and as a clinician, you guide the client through identifying the emotional parts of themselves that show up at a meeting table. So it's really starting to give name and identifying characteristics to each puzzle piece. So this client identified a fearful part of her and aged it about 6 years old, a submissive, very shut down part at age 12, attached and anxious, age 13, hypervigilant and controlling, age 15, self-destructive with substance use, self-harm, sexual behavior started at 12. She was really phobic to intimacy starting at age 16, but continued to act out in sexual behaviors because of the gain she received with drugs and validation. At age 21, she started to become very perfectionistic and controlling in many areas of her life while hiding a lot of the dysfunction. So half of her was known to people around her, and the other half was not at all. And this is at the bottom, there's a quote from van der Hart from his book, The Haunted Self. Without realizing it, I fought to keep my two worlds separated. Without ever knowing why, I made sure, whenever possible, that nothing passed between the compartmentalization I had created between the day child and the night child. So that quote really sums up what the psyche does when severe childhood trauma or continued childhood trauma takes place. In respect to my client, she identified being really fearful at about age 6. And when she pictured that part of herself at her meeting table that we identified in a visual exercise, when she identified that part as age 6, it was really fearful. She also identified that it sat right next to her adult self. And when she started seeing me, I think she was about 24 years old, and she felt completely tied to the fearful part of her in childhood. Which was really what was fascinating is she identified that part, but had almost no memory from age 6 where the suspected sexual abuse happened until her teenage years when she started using substances. And still today, the client has virtually no memory of those years in childhood. And, there's quite a bit of argument of whether it would be positive to get memories back. And often clients beg me to get memories back because they think the information is going to help them heal, but we can work with the dissociative parts and emotional parts of the personality without a lot of information, because it's tied to some memories, but a lot of feelings and sensations and functions of the parts that we look at, rather than necessarily why the part was or when the part was developed. Are there any questions on Fraser's dissociative table?
We have, let's see, we have a few questions. One is, I really struggle with the idea of trauma healing as it pertains to racial trauma because it's a persistent, constant, and reoccurring. And then she was saying that racial trauma isn't recognized in the DSM to start, that there's movement and conversations around it being included in the DSM-6.
So I would 1,000% agree, as much as I can, for being a white woman. But so I don't know if there's a question or if that was just a comment, because I think the systematic trauma that our world has experienced and is experiencing based in racism is real, and it needs to be addressed on one from the top of the DSM, that professional field, so it can trickle down into clinicians being able to appropriately treat it. What if I were to use this theory to treat racial trauma? It would be to really stabilize the different parts of the person that have experienced, if they have overt trauma in the past, that often feels triggered by what they're experiencing in current day. I don't know if that helps or makes sense.
Okay, let's see. The next question, can we say that dissociation is a kind of emotional suppression process used to avoid pain?
1,000% yes.
Okay.
Yeah. So another term I like to use to define dissociation is non-realization. Because part of the system's really fearful of moving into realization, because then the internal experience has to be acknowledged and treated. And most people feel very out of control when they're fully aware of their internal experiences from the past.
Okay, that's interesting. Let's see, what level of integration can a client expect when the trauma was a vehicle accident where they must still accept a certain level of risk when driving?
So, can you repeat that one more time? I just want to make sure I understand it.
So what level of integration can a client expect when the trauma was a vehicle accident where they must still accept a certain level of risk when driving?
Okay, so quite a bit of integration, because that would be a simple event trauma where the safety, depending also whose fault the accident is, that can add a lot of, or another complicated aspect to the healing process. So that's always important to keep in mind, is if the client ever feels responsible for the trauma. So integrating that emotional part with the AMP, assuming that there's one AMP and one emotional part, is going to happen a lot more smoothly than multiple emotional parts integrating to an AMP, because again, it is attached to safety with driving, while being able to keep in mind what is important to keep themselves safe today. So that would be a lot of adaptive information. Like, of course, I have to continue using my signal light, or I need to brake at a red light. That's all adaptive information. If a person is reacting while driving with maladaptive information or anticipatory fear, they are not integrated, or they have not healed from that trauma.
Okay. It's so funny. All of this is so far above my head, but it's fascinating. The next question is, there are people that experience different traumas through their life. How do these people do after treatment?
So I've seen it go both ways. It really depends on the symptoms and the person's commitment to the right type of therapy. Usually, if someone presents with complex trauma, it's pretty easy to assume that the first 6 to 12 months are really stabilizing the psyche and the person's idea of their internal experiences. I try not to enter into any reprocessing with people until I feel their neural network and nervous system is stable enough to do so. Because an unstable nervous system or a neural network full of maladaptive beliefs and experiences about themselves is going to move outside the window of tolerance unbelievably quickly. And then if the person is very drawn to self-destruction, that it adds in a whole element of safety. So there are a lot of factors when treating complex trauma, but I have seen numerous people move from a fragmented, completely dissociated, barely functioning human to a well-integrated person who is able to thrive in all areas of their life. With, of course, some spot check treatments throughout the years, which I think is really important to do.
That's awesome. Let's see. Do hallucinations, auditory or visual, automatically mean schizophrenia?
No. So there are numerous questions in the screenings for dissociation that ask if you ever hear voices that don't seem to belong to you. So this is going to be very common in secondary and tertiary levels of dissociation, because there can be very strong and apparent either different AMPs or emotional parts that really hijack the system. And that can show up with different identities, different voices, different genders even. It can show up in a lot of different ways. So it does not automatically mean schizophrenia.
Okay. When the person finds that the childhood trauma was so normal in their life, they are unable to connect negative feelings to them. Is there a way to help them do this in order to help them heal?
Yeah, so if someone is that removed from feeling the appropriate, feelings that would come after experiencing a horrific childhood, that's because their defense system, is so much online. So you work over time to explore the purpose of that defense system, the fears behind it, and most clients have such an intolerance for feeling calm that exploring their tolerance for calm and building the tolerance for calm so they're able to move their defenses down can often take months. So it's a lot of preparation and stabilization in order for a client to not act out in that defense system all the time.
Okay, and let's see, the last comment was, thank you so much, Chelsey, for the sensitivity in which you are answering the questions. Great job and much appreciated.
Thank you.
Those are our questions, so thank you.
All right, so I'm just gonna read this. This is kind of wordy, but it's important. So the parts of self that were developed during childhood allowed for the client to participate in daily activities, building the mental defenses and a level of non-realization of her home environment. She developed her own internal protection, and this is about my case study. So as the client moved into adulthood, the fact that the current reality was different from her past reality. So to note, this client eventually ended up getting sober, and that's when I started to see her. At this point, she was several years sober. She has a career. She is engaged and, is starting thinking about children with her fiance. All of those very normal parts of adult functioning have been extremely challenging for 100% of her system to accept. So for example, part of herself, right, an emotional part, wanted to move ahead in her romantic relationship. And this was kind of jumping around in our timeline, but when she first started dating her now fiance, A part of her was just frozen in time. It was a perception though, so it wasn't real because it's impossible to actually be frozen in time, right? But that emotional part of her perceived that she was frozen in time to when her sexual abuse happened and her domestic violent relationships. Okay, so the healthy, adaptive part of her wanted to move forward in her romantic relationship in current day, but it was getting the emotional part that was still in past time on board with the ANP. Okay, so she displayed and still continues to display a lot of phobia to intimacy and pretty flighty behavior. If there is an uncomfortable conversation or fight with her fiance, part of her system easily shuts off and just wants to detach from her current experiences because the vulnerability feels so scary. So furthermore, the apparently normal part of her personality functions, that word does not go, the functions had continued. Okay, furthermore, I apologize for the spelling error. That should say and continued to grow and developed into age appropriate abilities. So she started to drive when she was 18. She found full-time employment. She was taking care of her dog. She was maintaining friendships, right? Well, many other parts, again, had remained frozen in time. So these emotional parts of herself kept her feeling traumatized or were triggered when she felt re-traumatized, even though when she finally got sober and found safety, the trauma had stopped. So these parts of her are in constant defense against becoming traumatized again. So that is the dance when treating complex trauma, is really having an in-depth understanding of the internal self within a client. Because if you don't understand that, the behaviors are going to appear very erratic. They're not going to make a lot of sense to someone in the outside world. A lot of people think, well, they're just making the decision to mess up their life again, or why would they choose to do that? And while it's important that clients learn the importance of taking responsibility at some point, it is virtually impossible when a lot of their self is completely offline or only comes online when they feel that they're being traumatized. So a couple ground rules for treating dissociation. Our system was really designed for survival, not destruction. Meaning most clients I work with make it to my office because a part of them wants to get better, right? Even if it's only 10%, that apparently normal part has really stepped up to the plate to get them in the door. And a part of their system is just a part. This is, I think, where a lot of too much emphasis can be put on the emotional parts, in the sense that people can assume they're not going to recover or that part is inherently negative. So understanding the purpose of that part is really important to know that it doesn't have to always hijack. So we have to really get to know each part like it is a separate part, while keeping in mind that it is just a part of the whole system. So for every action, there will be an equal and opposite reaction, meaning the push and pull with attachment. Okay, this is often what we see with the disorganized attachment style that most of you have probably heard about. When we're all born wanting attachment and connection. Okay, so when we work to attach and then a caregiver traumatizes us and does not provide that attachment, the system is going to continue searching for that attachment. So our system is often in a push-pull all the time with one another. And that is really indicative of, you know, the symptoms that appear in people with complex trauma. So understanding that also the flip side of this, when someone experiences or acts out in a behavior, chances are the part of their system that wants help is going to bring them back to that help. And the therapist is the therapist for all the parts. So I'll have full sessions talking to one part of the system while ignoring or just keeping the ANP stabilized. But it's important for me when working with secondary and tertiary dissociation to understand the details of each part. Another quote by Dr. Fisher: "The essence of a dissociative disorder is the perfection of the ability to distance from affect in order not to become overwhelmed," which is indicative of our system's need for survival. So whenever emotions become unmanageable, our neurological circuit breaker system facilitates an automatic switch to another more tolerable feeling state. I was working, one of my friends has a pretty horrific past, and she's been actively engaged in addiction for several years. And a couple of us had to call her a few days ago to tell her that her dad was in ICU and he was, not going to survive. And on the phone, she said, "Okay, thanks, I gotta go." Okay. What happened inside her system at that point, because the overwhelm that she would have felt even for a split second was too unbearable, her system automatically switched to a tolerable feeling state, in her case, complete dissociation and shutdown. Okay. So it's a pretty, once you're able to recognize that within your clients, it is very effective in kind of titrating between what is tolerable for them and what's intolerable. If we push clients to intolerable too often, they're going to just remain in dissociation. So it's really effective to understand how to dip into the intolerable state and then help them find stability again. Symptoms of undischarged traumatic stress. So this is from traumahealing.org, which is the website for somatic experiencing training. This theory was developed by Dr. Peter Levine, who really integrated theory with what he witnessed in the wild, in watching wild animals not present with PTSD, even though they are in constant state of distress and threat to their lives if they're not, if they're prey every single day, all day, but they do not present with PTSD. And that is because their nervous system, while it functions the same as ours, they don't have the very developed frontal cortex of their brain that we do. So while they move into sympathetic or parasympathetic response, just like this chart shows, when a traumatic event happens, they're going to run for their life from the predator. And then if they don't get caught and are able to get away, their body literally shakes and discharges that traumatic energy. Okay. And then they go back into normal range. What happens for humans, because our mind interrupts the process of discharging that trauma, we start to think, why is this happening to us? What did I do wrong? And more the shame and the guilt starts to kick in. And that leads to the black line of the severe up and downs and the feelings of stuck on, which are represented by anxiety, hyperactivity, startled response, inability to relax, restlessness, hypervigilance, sleeplessness, etc. Often when stuck on feels too overwhelming, the system's going to move to stuck off. And that is dissociation, exhaustion, chronic fatigue, depression, disconnection, low blood pressure, poor digestion, pain. And the list goes on of the different things that we can experience as a result of traumatic stress. So EMDR, eye movement desensitization reprocessing, is the leading modality in treating PTSD. It is something I am trained in, and I was lucky enough to be trained by someone who specializes in complex trauma and dissociation and dissociative disorders. So while I got the background of using EMDR for single event traumas, I was provided with several additional hours and have since, added a lot more to my training in how to use EMDR to treat complex trauma. So like I've been talking about, any modality used to treat complex trauma requires very careful modification to attend to and attune to the highly dysregulated nervous system and other dissociative symptoms that accompany complex trauma clients. So stabilization and preparation for reprocessing is key. There are 8 phases of EMDR. Phase 2 is stabilization, and I'll typically hang out in stabilization with very complex trauma clients for months. That doesn't mean we never dip our toes into material, but we dip in our toes and we pull out to find stabilization. So many of my clients have never felt safety before. So teaching their system that safety is important to their recovery has to be imprinted in their mind over and over and over, just like the negative messages were that led to the trauma. So it's really vital for all therapists to slowly guide the clients to build tolerance for distress and tolerance for remaining in calm too. And I know that seems kind of opposite, but most people who have complex trauma are so used to being either stuck on or stuck off, and they don't know how to live in the normal distress window of tolerance. And complex trauma clients often live outside their window of tolerance before therapy. So they're in freeze, which is stuck on, dissociation, stuck off, and then jumping right into reprocessing or asking a client, tell me all of your trauma, often just pushes them further into a non-realization dissociative state because their brain's like, this is intolerable, I'm going to go offline now. So EMDR can be highly effective for treating complex trauma. It just has to be modified. And then somatic experiencing is something, is a framework developed by Peter Levine, like I was saying before. And this framework I really integrate with all of my clients, whether they have complex PTSD or not, but it's a body-centered approach for healing trauma and anxiety-related disorders. Like I've been talking about, trauma clients suffer from high levels of somatic overwhelm, whether it is related to a single event or chronic traumatization. This framework is pretty fascinating in the sense that there's not a lot of talking. We don't need to know the itty-gritty details of every trauma to unlock it from the system. The head-heart disconnect that most people with trauma experience have a really hard time even recognizing that head-heart disconnect because the integration or even the thought of the integration is too painful. So this framework is very slow. We work to track somatic sensations and slowly connect the psyche back to the body. And once we have been able to connect head and heart, and really prime the system for stabilization, then we can start reprocessing and moving the body through the event again while discharging the energy without moving the client outside their window of tolerance. So somatic experience training is quite a long, in-depth training. It takes usually at least 2 years to do, but it's pretty amazing and effective if you are interested in working with trauma-related disorders. And then I'll kind of end, I'm just gonna check the time. Yeah, okay, so I'm gonna end with this thought. So if we start treating complex trauma as a dissociative process rather than an anxiety disorder, I believe we will see more intricate healing. And it's not, and I'm not saying that the anxiety presentation of trauma isn't important to treat, but I believe treating the anxiety is a one-layered approach, and we have to understand all the working pieces of a person's psyche, why and how they were developed in order to appropriately integrate one's whole self into the healing process. I think reflecting back, I made so many mistakes in my early clinical career where I truly thought that the work I was doing was effective. And I think it was effective for 50, 60, 70% of the person. But again, that large chunk of their psyche that really has been dissociated and in a state of non-realization stayed there during a lot of talk therapy. And until I learned the structural dissociation theory and how to implement it and integrate it with somatic work and EMDR, I truly didn't feel the connections that I have now with my clients' trauma process. So thank you, Aurora, for inviting me to speak on this topic. And I hope there are more questions. I love discussing this topic and learning from other people who treat trauma, because I think it's just so fascinating, and I have so much more to learn. So please hit me with information too, if there's any of that or more questions.
There are lots of questions. So, okay, the first one, so can dissociation cause resistance, or can dissociation be misinterpreted as resistance of the client?
1000%. Because a part of their system is resistant to even recognizing and moving to a state of realization that something happened to them or that it negatively impacted them. So it's important to remember that the defense systems that are developed during traumatic events or throughout someone's childhood have served a really important purpose in that client's survival. So when we ask them to strip away certain things, we're in a sense taking away their ability to survive if we don't replace it with adaptive information and appropriate therapy.
Okay. Let's see, the next one, when they're both stuck on and stuck off in the same person at current, what's the best direction?
Okay, so what I always do is start with psychoeducation of the nervous system. And I often draw the graph that I had in my slide on a whiteboard when I'm working with clients, because it's important for them to understand where their system is sitting at and the reason that it's there. I try to really carefully watch the language I use and never identify something as positive or negative at first, because I don't want to judge what their system has automatically done in order for survival. So I do a lot of titration with somatic experiencing, moving from pleasant to unpleasant, and testing their nervous system's ability to experience something that isn't typical.
Okay, let's see. How does a person who is functioning relatively healthy but senses disconnect from heart and emotions begin to connect head and heart?
So that is a complex question. They have to find a therapist who is trained in dissociation and truly understands the dissociative process as it relates to protection and survival. So there are different, this book, I wonder if I hold it up, because can everyone see this book?
I think we see your screen.
Okay.
Maybe if you stop screen share, I think it would show it.
Okay, there we go.
There we go.
So I can also put it in the chat, but it's coping with trauma-related dissociation. And this really is a guide for clients and therapists. There are actually two versions of this, one for therapists only, this one's for client and therapist. But I often work through this book with my clients, kind of in stages. I really jump around, but it helps to, there's so many different chapters on stabilization and what that means for the person's nervous system, because until they're willing and able to recognize the dysregulation and consequences that they do experience as a result of their trauma history, it's pretty unlikely they're going to seek help. So as long as there's a purpose and they feel some sort of security from it, they're not going to be really eager to change. And that doesn't mean they don't want to change. It just means that the survival strategy that they have is really working. And I'll type the name of the book right now.
Oh, perfect. Do you give your clients homework such as mindfulness exercises, or is that too risky because this could trigger EP states?
Yes and no. So I really, depending on the client, sometimes I do give a lot of orientation and regulation techniques for them to practice. But if finding calm for even 5 minutes dysregulates them too much, I don't have them do anything. I will often refer them to join a DBT group. If possible, see me twice a week so we can spend one session stabilizing and the next kind of applying those stabilization techniques to some material.
Okay. What's the single most effective tool to give an incarcerated person with CPTSD?
Are they going to be incarcerated for a very long time?
It does not say yet. So we can jump to the next one and then come back when it's, let's see. I have heard brain spotting is more effective long-term for PTSD than EMDR. Any thoughts?
So I can't really speak on brain spotting. I'm not trained in it. And I know it can be effective, but I just don't have enough information on the mechanism behind brain spotting. And I know, so when you're looking at complex trauma and trauma-based and attachment disorders, and trauma from caregivers, it's going to be, I don't believe one method is the end all be all. So I don't believe that EMDR is the end all be all for treating that type of trauma either. I think it's really a combination of modalities.
Okay. And my personal question, how many people are walking around like in this state, but they don't even realize that they had trauma? And like, what happens if they never get help?
So, sorry, I'm just typing this artist or the author. I mean, I would assume there are millions of people walking around with some sort of untreated trauma. I think one of the most unresearched aspects of trauma, historically anyways, has been narcissistic abuse, emotional trauma within the home, because those are more widely acceptable traits from other people because they aren't physical or sexual in nature. So I think they are really seen as not as impactful to the development of the psyche. So I think there are probably an abundance of people walking around with a lot of emotional trauma related to nuclear family systems and caregiver relationships that can highly dysregulate and damage the psyche.
Okay, thank you. Let's see, pertaining to the former question regarding incarcerated persons, how does a clinician assist them in identifying their dysregulation and arousal when in constant state of sympathetic dominance because of the environment?
Yeah, so I mean, that is just such a tough environment to find any sort of regulation because there is the reality factor that they have to maintain a level of safety and hypervigilance. So I would have them really ask themselves if what they are feeling is 100% needed in that moment. For example, if they were in their cell by themselves and the doors were closed and they were reading a book and they felt high levels of anxiety, I would have them really orient to their space, recognize if they're able to a level of safety that they feel because of their personal checklist of why they know they're safe in that environment at that moment. So I think if we can teach people who are incarcerated to even find moments of stability and regulation, and they're able to practice that daily, their system will eventually be able to kind of bounce back from dysregulation a little quicker. It's like priming the system for finding even small levels of stabilization.
Okay, let's see. Someone asked, how old is your oldest client? And is it more difficult to treat older people?
Yeah, so my oldest client, well, I don't work with her anymore because she moved, but she was 62. And this woman's life story was just mind-boggling. And in a way, it was harder to treat because the defense system has been activated for so much longer than in, a younger client. It doesn't mean it's necessarily harder, but it really depends on their personal demand for change. She had high personal demand for change. She eagerly wanted to recover from her traumatic past. I had another male client with a horrific childhood, but a very well integrated adulthood, except for kind of a sliver of his functioning that his partner wanted him to get help for. And he, after a few months of after it was just a couple months of treatment, really started to fall off because the internal awareness of his experiences, even though we went at a snail's pace, it really spooked something in him. And he's questioning, why do I even want to open this door? Right. And I understand that. It's hard to answer that sometimes for people, depending on their presenting situation.
Yeah, I imagine a lot of people are probably like that.
Yeah.
Why even do it? Like if I'm functioning and I'm getting through life, why
would I do this?
So to speak. And let's see, then just a ton of comments on how awesome it was. I wanted to find that one because I really liked it. There we go. Someone said, thank you very much. That was one of the greatest seminar I attended. Thank you all for making this happen.
Oh, yeah. That's nice.
I love that. Yeah, I think that, one more is, what are your go-to safety and stabilization skills or techniques? And then, do you have many chronic pain patients?
Okay, so go-to safety and stabilization techniques. Something I learned a couple years ago is that I really loosely threw around the term safety or calm without understanding its implications for some people, because some of my clients are like, safety, calm, what the heck are you talking about? That is not something that's even in the realm of possibility for me. And so number one has been like changing the language I use, or asking a client what they prefer me call finding a safe place or a calm place or a place of solitude for them. So I do quite a bit of visual exercise and time and place orientation. Those are the go-tos that typically don't send the nervous system outside the window of tolerance. So a lot of somatic go-to stabilization techniques can absolutely dysregulate someone. And it's not to say they aren't effective when used correctly, but they can sometimes. Somatic work is just unbelievably overwhelming to the system. So I really stick to, in the very beginning, until I know their system more, is to time orient, space orient, age orient, so they really are able to orient to their present safety level, and visually being able to find somewhere that they can go that they are able to couple with a calmer nervous system.
Awesome. Well, that looks like all of our questions. This has been so fascinating.
Well, I'm really grateful for all the wonderful responses. Thank you.
Absolutely. Well, I'll tell you what, if you'd like to if you have an email and you want to share it, if folks have additional questions, it's always an option as well. Just thank you again so much for this presentation. It was fascinating and had so much just information that I don't think is always out there. And so I really liked all the graph you had that kind of showed where each level was and everything else. So thank you again for the amazing presentation. We'll do a virtual round of applause. I know everyone has their stuff off, but just so that it's there for everybody.